Thank you. It's really a great pleasure to be here. I just want to also acknowledge the traditional owners of the land that we meet on, the Gadigal people of the Eora Nation and their elders past, present, and their emerging leaders. Can I also acknowledge all of us here today with a lived experience of mental illness? I don't think I've ever been in a room where I felt so confident of that fact. But of course it's true everywhere, and this is the reality of mental illness in our society, that it is rare that you'd ever be with a group of people, particularly when you get up around 100, to not have people who have their own lived experience or people who are caring for loved ones. And it's a reality which sometimes is lost on those responsible for the services that we receive. Can I also thank Lana for her acknowledgement of lived experience. I think whilst we've become very adept, I think, at acknowledging the traditional owners of the land, we really do need to recognise in meetings such as this just the importance of lived experience, but also the leadership of that experience. And the only way we can really do that is by acknowledging it up front. Can I also congratulate Being, or CAG as it used to be known, on what is now, I think, its 30th year of operation. And because this is not its actual birthday, I think, I just want to get in early. Can I just look, it is an honour for me to be here, to be given a chance to reflect on the establishment of the Mental Health Commission in New South Wales and to share my thoughts on that and some other things, and hopefully a bit about peer work. I think really, in terms of lived experience and peers, it's so embodied in what the Mental Health Commission is that it will become clear, I think, in what I have to say. So it's almost 5 years since I completed my term as the inaugural commissioner, and since that time, whilst I've been whilst I've been appointed as a part-time deputy president, I should say, of the Mental Health Review Tribunal, and I'm seeing, I suppose, mental health at the sort of coalface in terms of severe and persistent illness, both in civil and in the forensic system. I've really nowhere near the immersion I had and the actual honour I had and the privilege I had for those 5 years of being so involved in all issues related to mental health and wellbeing in our community. And so it's really a great chance for me, and it's been a welcome opportunity for me to reflect on that time. Can I just say that commissions should be change agents, and this will often involve being disruptive irritants or catalysts for change. Establishing a commission and giving it the necessary functions is really a very brave political move, because like royal commissions, the outcome of a properly functioning mental health commission is not necessarily predictable. So you've got to take a leap of faith. It requires political courage, and that is exactly what the New South Wales government demonstrated in 2012. And I want to acknowledge in particular Minister Kevin Humphreys and the ministry at the time, particularly David McGrath, who was then Director of the Mental Health, Drug and Alcohol Office, for what they did and how they went about it. The fact is, when the Commission's legislation was tabled by Kevin Humphreys, people with lived experience were very well represented in the galleries. It was quite clear that they'd gone about the process of working out what should be in this legislation quite well. I mean, the legislation itself, of course, placed lived experience at its heart by requiring at least one commissioner or deputy commissioner to have a lived experience of mental illness. But not just that, the minister, Humphreys at the time, tasked Being, or CAG as it was then, with consulting on what should be the commission's focus initially. And that broad consultation produced a report called Border to Border, Visions of Hope, which was available to me in August 2012 when I commenced. And it did help guide our work. When I was appointed, the other thing is that Kevin Humphreys was remarkable, I think, amongst ministers I've known, in that he made no attempt, and I mean no attempt, to tell me what to do or to suggest what I should give priority to. In fact, the closest he got to anything along those lines was to say, "I'm sure you'll work it out when you get your feet under the desk." And I've got to say, it was incredibly reassuring and enabling of us. But at that stage, I can't say I was involved in the process for the development of the commission, for the commission at the time, and so I didn't really know a lot about it. I knew I wanted to do it, and of course I'd read the legislation. But on my first day in the job, I went to the tribunal where I was the deputy president, or had been, finished off something I needed to do, and then walked across the grounds from the tribunal to the Commission's new home on the Gladesville Hospital site. In doing so, I walked past the office that my grandfather had occupied as a superintendent of the old Gladesville Asylum. I then walked past the home that butts onto Victoria Road where my mum and her siblings and my grandparents lived. And I walked further up the road to get finally to the Commission in Shea Close, where I'd live for the next 5 years. And I can say in many respects that I did literally live there for the next 5 years. So it was a strange journey for me. I'd stayed there at the age of 5 in 1961, probably in my granddad's last year. I'd heard my granddad probably very inappropriately warn us, because we used to chase him down the back stairs, what is now a preschool, but was then his home. We'd chase him down the back stairs as he went to the gate to go into the hospital grounds, and he'd say, "Don't follow me in here. They're all mad." And he'd slam the gate behind him. And then just when we thought he was gone, he'd put his head over the fence and say, "Even the patients." So he had a good sense of humour. But also, he later told me just the regret he felt about his history in that place, and the fact that, with the development of psychotropic medication, suddenly all of these people who they thought of as hopeless cases were actually released into the community. Long before there was a formal attempt to close asylums, people were suddenly entering our community. So can I tell you, I'm a relatively anxious person. I tend to start work ridiculously early so I can feel less anxious about what the day has to offer. But when I got to that commission, that building, it was beautifully renovated, I've got to say, what I found was a small bunch of borrowed staff from Being, or CAGS, what them was, a RAFMI and Way Ahead, and a few from the ministry. And we went up to the boardroom with this magnificent old table where the board used to meet. And we sat around as a small group and we just got to know each other. And I can tell you that within an hour and a half, I felt completely at home, and I felt incredibly confident that we as a small group would know what we had to do. And borrowing staff, whilst it was a necessity, because when I arrived, we had nothing. We had no policies or procedures. We had no way of paying anybody. We had no systems in place. So literally we're relying on borrowing what we could do. But the fact is, it was a bonus. The skeleton staff had just the right mix of lived experience, community and ministry skills. We had the wherewithal to make a start on this sort of demanding job of both creating an organisation with budgets and policies and procedures, and also being outward looking towards the world. And a bit unlike the National Commission, which started around the same time, they had 6 months of closed doors to get themselves ready to meet the world, whereas we didn't. We were a bit more like the NDIA. We were sort of building the aeroplane and flying it at the same time, And it was a challenging, at times breathtaking, but also really useful thing, because of course when you have to do things, you come up with better ways of doing them. And I think it really encouraged us and it required us to adopt a couple of strategies. And the first was that we were completely open to partnerships from the beginning, especially with peak bodies. We reached out immediately. It also made us realise and crystallise really early on that whilst we were there as an organisation to identify and stimulate and facilitate change that was required, we actually didn't have to do it all. And we weren't there to do it all. It was about the health districts and the NGOs and the community needing to take up this challenge. And by doing that, we didn't waste as much time as we might have wasted if we tried to literally fix all the leaking holes that were then in the system. We also realised quite early, identified and took advantage of a very interesting and unintended consequence of the Commission's creation. And that was that there was broad uncertainty, both within the ministry, within local health districts and with NGOs and the community, about who we were and what we were and how much power we had. Now, and I don't mean this in a cheeky way, but the fact is, temporarily, this left a vacuum, and others we found, whether they were health districts or NGOs or researchers, tended to fill that with whatever their hopes were for the Commission. And so it meant that everybody came knocking, from local health districts to peak bodies, NGOs, clinicians and researchers. And for a period, it was really apparent to us that we would need to be all things to all people. in the space. And we needed to harness this to establish a strong presence, build momentum and to forge relationships, which we did. We developed early close relationships with some local health districts who approached the Commission because they were actually very keen on innovation. This allowed us, at an early point in time, to embrace a role with the local health districts that approached us as sort of a critical friend, which was really the appropriate way to move forward. But there were huge expectations and with it huge opportunities, which I have to say we willingly embraced. And looking back now, what amazes me was how accepting and courageous and excited our small group of staff were with this challenge. There was a lot of creativity in the room, but lived experience provided the drive and the clarity of purpose that we easily could have lacked without it. So I'm forever grateful to all of those who are there, but also I'm grateful to the Minister and to the Ministry for giving us this, for organising the fact that we'd have these people available to us. Fortunately, in early 2013, Faye Jackson and Bradley Fox-Lewin were appointed as the Deputy Commissioners with lived experience, and I can tell you they greatly extended our confidence, expertise and reach. I'll never forget that Kevin Humphreys rang me because there was his absolute delight when Bradley Fox-Lewin appeared on the front page of the Sydney Morning Herald with one of his therapy horses. And the Minister was so overwhelmed by the presence of this story on the front page of the Herald, he thought the job was done. I think I should have then and there asked for reappointment because he was completely impressed that this was big news, the fact that we'd made it to the front page of the Herald. Soon after, our advisory council was appointed and they brought a vast amount of experience across the sector, a hell of a lot of goodwill and additional lived experience, which really, again, enhanced our approach. Can I say we also spent a lot of time exploring our own legislation, our functions and powers, and by fully embracing this role, it gave us licence to confidently pursue, in a broad sense, reform and to engage with central government, such as Premier and Cabinet, and also national bodies in a very independent way. We moved quickly. We occupied the space, and you've got to do that. You have to look at your powers and you have to do everything you can to make your presence felt. But this was particularly important, can I say, in the early days when it came to perhaps the biggest thing that was happening in parallel with the new Commission, and that, of course, was the NDIS. It was indeed a time of enormous change, because at the same time as that, Medicare locals were becoming PHNs and their roles were changing. So all of this was up in the air and we're just waiting for those pieces to land. With the NDIS, we were in the door early and we hosted meetings at Gladesville with the NDIA chair, Bruce Bonahady, and his senior staff from NDIA. And we talked about what recovery meant in the context of a deficits-focused NDIS. And we talked about how a person with a severe and persistent mental illness could be assisted to access the NDIS even though they didn't accept they had an illness or a need. And the NDIA came to accept, I think with our advocacy, the need to accept that NGOs who had worked with these people were the best ones to help them access the NDIS. And it wasn't what was intended. Initially, the plan was to exclude all of the NGOs who'd worked with people with severe and persistent illness in some bizarre expectation that the people would work it out for themselves. And that was because Bruce, I think, very sincerely believed it should be about choice, which of course it should be. But it's not helpful if the person has got no way of navigating a very complex system. And so they moved quickly on that, and we were very grateful. But because of our broad early engagement, we could see that many parts of the mental health sector did not appreciate the impact the NDIS would have. Whilst it was an enormous potential to benefit consumers and their families and to reduce the burden on the public hospital system, it was also clear that many NGOs did not have the capacity to survive in the new environment. It also took a while, frankly, for health to fully appreciate that the NDIS would truly deliver new funds for psychosocial disability. It was a rare thing in a reform space where the pie wasn't just being divided up again. It was actually a bigger pie. But we all had to realise that and move on it quickly. With this in mind, we held forums about the future to challenge NGOs to think about what the future would look like and to get ahead with the changes that were coming. And that included, for many of them, actually contemplating whether they were of sufficient scale to cope in that new environment. Similarly, we're able to participate in Premier and Cabinet processes to ensure that New South Wales was ready and willing to take advantage of whatever steps were necessary to make sure we got our share of those NDIS packages. And at the same time, we liaised with the NDIA to keep bringing them along that path of grappling with psychosocial disability and recovery concepts. And I want to acknowledge the amazing job done in the Hunter region by Dr. Martin Cohen and his colleagues, for running one of the major trial sites and demonstrating to his colleagues what could be done if you put the energy in up front, if you actually put the time in as a clinical team to do the work to help a person access the NDIS. And at the time, we were also at pains to make sure we aligned ourselves with other agencies or other entities such as Mental Health Australia to make sure that our messaging was at one with them, so that we couldn't let there be any wriggle room with the NDIA in terms of how it rolled out those benefits. So I'm proud of many achievements, and I just want to, though, touch on a few which are really particularly significant. Clearly delivering Living Well, and I think I might have had a photo, I don't know whether that got up or not, a photo of some of the reports, but anyway, if it's not there, that's okay. But Living Well, the 2014 to 2024 strategic plan for mental health, was a legislative requirement. And we achieved it through what I think was an enormous statewide consultation, which really had the effect, I hope, of democratising that process by reaching over 2,000 people and entities. This included, again, engaging Being, or CAGS it then was, to do a broad consultation with lived experience. And throughout the consultation, we also made sure we engaged with all priority populations and diversity. The fact is, though, strategic plans can make very dull reading. And we recognise this. Very fortunately, one of our amazing early senior staff was Julie Robotham, who'd been the lead health writer for the Sydney Morning Herald. And Julie put it to me that we needed to do something that was more accessible. And so Julie went out into the community and put together the Living Well, Putting People at the Centre report with a high degree of videography and other supports to really tell a person-centred story about what it would mean to implement this strategic plan and why it was necessary. And I can tell you, it was ready at the same time that we were ready to table our strategic plan, but government took a while to consume the strategic plan and decide how it would best support it. So before they agreed to it and supported it and approved it, we tabled the other report in Parliament, and that allowed us to get out into the community and talk about what was intended. We also built community champions to tell the stories across New South Wales about what that plan would deliver. The plan has many aspects to it, and I hope that some of you might be familiar with it, and it is the Commission's role today on an ongoing way to monitor the implementation of that plan. But given the institutional nature of mental health as a history in New South Wales, I was particularly delighted when the government approved the implementation of the recommendation to deinstitutionalise, or to finish the deinstitutionalisation process. And they did this through Pathways to Community Living. And I want to acknowledge the remarkable work of Robin Murray and her team in implementing that program. Now, I regularly encounter PCLI in both my forensic and civil hearings on the tribunal. And there's no doubt that a combination of the New South Wales Ministries or Health's HASI and HASI Plus packages, together with the NDIS funding, particularly around supported independent living, has actually been transformative for people with severe and persistent illness. It's done a hell of a lot to decant not just our civil hospitals, also our forensic hospitals. And so I'd just like to say this, that you'll hear lots of attacks on the NDIS. People will say, oh, it's not very efficient and there's not lots of wasted money. Well, I can tell you it has been transformative. And you know what? There's lots of inefficiency in public hospitals, but no one suggests that we should close them. And I'd ask all of you to make sure that you advocate for the NDIS whenever there's an attack, because there may be some room at the edges in terms of dealing with efficiency. I'm sure there is, like all human endeavours. But at its core, in terms of who it's helping, it's unquestionable. Can I tell you, Prue Goward, who was Minister for the time, in fact, we had, after Kevin, in total, we had 4 ministers in 4 years. When Prue was Minister, we were implementing the reforms around PCLI, and they started very sensibly with the aged care cohort in our long-stay public hospitals. And Prue rang me because she'd taken a team of people from Orange, Bloomfield, to visit an aged care centre in Redfern, where a lot of people from Bloomfield had gone. And she rang me absolutely delighted to say that a couple of the nurses who'd gone with her there were actually reduced to tears with happiness with what they encountered. Because people who had inappropriately, in an aged care cohort, been sitting in Bloomfield Hospital with not a lot to do, were suddenly in an appropriate aged care environment, where every day, when Prue arrived, one of the people who she knew was standing at the counter holding the hand of a receptionist who was doing data entry. Another one went by and said hello as he went out on a truck to do deliveries and pickups for this particular facility. And it was really simple. It was simply moving people into an environment that was more appropriate to their needs. And I can tell you, it wasn't lost on New South Wales Health and government that we successfully, in that one move, moved that entire cohort of people from a state-funded entity to a Commonwealth-funded aged care entity. And there's a lot more of that can be done today. But yeah, we just need to be conscious of it. Look, and I can say PCLI is much harder. As you go down the age cohorts, it is much more difficult to come up with appropriate arrangements in our community. And I respect the fact that they're trying to develop those models. And we are seeing good work happening, but it is an ongoing challenge. Can I say the plan also emphasised the importance of the development of a peer workforce. And the government at the time, when it announced its acceptance of the plan, even talked about funding the potential for an organisation that would actually be a sort of a peer backbone organisation. Now, look, I've got to tell you, I'm not really across where we've got to. What I can tell you is that 5 years ago, when I completed my time as Mental Health Commissioner, I could not have imagined being in a room with all of these peer workers in it. So we've certainly come a long way. So whilst I tend to carp a bit about what we've not done enough of, I do recognise that we are clearly moving and we are making great steps. I can tell you, though, as a tribunal deputy president, I often do hearings where I wish there was a peer worker in the room. So we still have a fair way to go, but I'm not criticising what you're doing, okay? And with that, can I say, I acknowledge that we still don't have a national peak body for lived experience, and I think if we did, it would help to push the barrow for this, and I would certainly encourage its development. Can I just say, I want to touch on a few other areas which really demonstrate the Commission's broad engagement. I suppose things that I was proud of at the time. I was very lucky because I got to be involved in a thing called the International Initiative for Mental Health Leadership. And I was overseas once a year with that group of people looking at how other people were coping around the world. And one of the things I stumbled on when I was going through Philadelphia Station was this marvellous thing called Check Up from the Neck Up. And this was essentially a group of, it was run by their local health centre, and it was really taking mental health to the public. And they had big banners with bright colours, and it really invited members of the public to drop in and get a check-up to see how they were going. So I came running back, of course, and I have to say my staff at times at the tribunal would say, oh no, what's he got now? You know, what shiny object has he seen out there that he wants us to play with? But we talked a lot about this idea of, because not only is it a good idea to be out there to give people a chance to encounter mental health resources in the public sphere, but it's a way of educating, it's a way of promoting, it's a way of doing something which we realised was really very special in this. It was a way of bringing peer workers and clinicians together in a public space where they could demonstrate how they could work together. So I can tell you, when I raised the idea, and I borrowed a lot of the concepts from Philadelphia and a lot of their badging, I must say, we did a big consultation. We had the ministry, we had health districts, Ambulance New South Wales, all in the space at the Commission talking about what would happen. And I've got to tell you, initially, the ministry and the health districts were terrified. What they said, and one of the health districts in particular said was, John, if you set up this thing like you want to do in Martin Place, with big banners saying check up from the neck up, you know, what happens if we encounter people in crisis? And there was a dead silence in the room. And I couldn't believe some of our peers wanting to jump across the table. But eventually someone from one of the other health districts said very, very sagely, what happens if we don't? You know? And I can tell you, within a very short period of time, with amazing assistance from Ambulance New South Wales, with extraordinary cooperation with the health districts, and of course with the peer workers, we were able to do our first in Martin Place, and it was just overwhelmingly positive. I mean, we did, and we got people, of course, coming in and sitting down and talking about the stresses in their life, and we did have a triage system for sending people off to get other care if they needed it. But there was no disaster in it. It was a warm, welcoming space, and that was entirely to do with the peer workers and the fun that they made it. It was a fun space, it was a welcoming space, and the LHD clinical staff worked brilliantly together, and we had ambulances, we had ministers coming down and politicians dropping in, and it was and we went from there to the Royal Easter Show, and David Hurley as governor got involved. I mean, people really embraced this concept of being out there. There should be nothing hidden about our mental health, you know, and there should be every opportunity for a person. Can I just say, I went to Mudgee once, and a cab driver said to me, "Can I have your cards?" He said, he said, what I do is, at the time he had his taxi card, and he'd often given it to women if he observed they were in trouble, if they were having conflict with their partners. And on the back of it was a number for them to ring, which would get them in touch with support services. And he said, so I'm going to put yours on the back as well. Because, you really got to provide people with every possibility of engagement. So, look, it was a fantastic thing. And I don't know, we went to Chatswood and, we tried it with different population groups. It never failed to get a good response. The other thing I just want to touch on from that period of time was back in 2015, we held the Peer Work Forum. And I'm sure probably many of you were involved in that. But on that forum, and I looked back at the video yesterday with Faye Jackson and lots of people speaking from their own experiences in this area, we had in the room some of the early adopters, employers who like Flourish, who were doing early work in the space, but we also had health districts and other NGOs who would, I have to say, I'd put them into the category of being curious. They hadn't made a commitment, but they were curious to know what was possible. And that day explored, and we didn't dumb it down. We looked at the legal and other challenges, because all employment is inherently difficult and complex, and you've got to be very careful how you go about it. But it created real energy in the room about what could be achieved with a peer workforce. And, through that we had the Peer Hub, which is still available in terms of resources. And again, I can't tell you where all of that's at, but I know that when I went back and looked at the video yesterday, the energy and the enthusiasm was electric. And I can say, because I can see the numbers in the room today, that clearly the movement is going on. We just need much more. Can I say, I also want to mention to you another vital thing that happened at that time, which again demonstrated the way in which we're working. And that was, we put out a report on medications and mental illness. Now, I think all of you, or many of you would know here, just the disastrous consequences of polypharmacy and metabolic syndrome. Now, when we went into this space, we did it by, I put together a pharmacotherapy advisory group with the chief pharmacist, the chief psychiatrist, LHD representatives, researchers, Professor Tim Lambert, who ran the metabolic program, carers, and people with lived experience around that table. It was a fascinating discussion, because I can tell you initially, and I don't think I'm offending anybody by saying, there was a lot of clinical anxiety around that table. There was a lot of fear that we were asking for the impossible to happen. And I can tell you, as a tribunal president, prior to becoming commissioner, it was really common to see young men in particular who were on 5 different types of antipsychotic medication, who had blown out in their weight by 25 kilos in 18 months, and treating teams saying, but we've controlled his symptoms. And you go, yeah, but he's dying of metabolic syndrome. And they say, yeah, but we've controlled his symptoms. And they had no pathway back then to find out a way of rationalising the medication to getting down to what was needed. And they're the sort of discussions we had. And we did a major survey at the time of both consumers and carers and clinicians. And what that survey was revealed was the widespread unhappiness amongst clinicians and others with the way that things were working. And we sat around our table and, I was waiting for the findings to resonate amongst our group. And of course, for the consumers and carers, there was no mystery in this. They knew well what the problems were. The question was, what were we going to do about it? And as I looked at the hesitancy around the room, our chief pharmacist at the time spoke up and just said, well, it's just overwhelming, isn't it? There's no way in which we can question the outcomes of this research. There's no way that we can question the need for us to act. I can only say from my own experience of doing hearings on a regular basis that I see much less of the gross polypharmacy that we used to see. I mean, I still see it, but nowhere near at the same levels. And the fact is there's far more commitment now to monitoring metabolic syndrome and to making sure that some of the dire consequences of that terrible deal we do between medication and mental illness. And like I say, within that grouping, we had some fantastic discussions about people like the Hearing Voices group. I'll never forget standing in Melbourne in the cold with a group of people who were all the Hearing Voices group, and they were telling me about how they were living happy lives with their voices and having dramatically reduced their medication load and dramatically improved their health. And I was so naive. I said, what's it like? Do you always hear voices? Are you often hearing voices? And all of them said to me, John, we're all hearing the voices right now. We're just all entirely happy with them. And so, that to me was an eye-opener as a sort of a naive lawyer. I took that back to that group, that we shouldn't be trying to solve things that aren't problems. The fact is, if people are happy to live with some aspects of what might be an underlying illness, we should be embracing that. Can I just say that the impact at the time of lived experience on that group, the peer workers and others and the carers in that room, was transformative. And I remember when we delivered on that report, Murray Wright, the chief psychiatrist, spoke at Being on the launch and absolutely made didn't hesitate at all to embrace entirely what needed to be done. And I remember Faye Jackson, who's very funny on many occasions, got up and said, I've only fallen in love twice, really. The first time was my partner, and the second time, Murray, it's with you. And I had never seen him look so uncomfortable. But delightfully so. Can I just mention a couple of other things? Again, in terms of trying to bring about change, one of the great things we did with community was the Speaker's Garden event. I don't know whether any of you got to go, but every year we take over the Speaker's Garden at Parliament House with the community NGO groups. And it became what was said to be by many politicians, including Mike Baird at the time, one of the most popular events they had. It was a barbecue in the Speaker's Garden. Now, my initial suggestion was that we should occupy Parliament House for 3 days, and it was sort of whittled away down to, they thought 3 days could be too much, although I think it could have worked. But the Speaker's Garden event was just fabulous, and it was initially Mike Baird as Premier and then Gladys Berejiklian. But it was said to me by the parliamentary mental health support group that it was the most popular event they had of the year. People came out, they mixed with the community. A lot of them knew the community groups there. That was like Mike Baird, for example, had a lot of involvement with Schizophrenia Fellowship Clubhouse up in his area. So it really showed a lot of the politicians who were conversant with mental health issues in their community, and it showed the ones who wanted to become so. So it was very important. Can I say, we're also very proud that earlier on we helped develop and support the development of the National Aboriginal and Torres Strait Islander Mental Health Leaders Group. Now, I don't know if you know this group of people, but they're from all around Australia, and they came together to firstly work with us around some issues to do with mental health issues and Aboriginal people in New South Wales. But they went on to be an independent standing group funded by the Mental Health Commissions to carry out that work. And we were very proud to have them as partners in the work we were doing. I just want to mention also about research, because I'm so pleased, I know on the Black Dog Institute, to see the degree of research that's happening. But back then as a commission, we tried to target across many spheres, and we knew the research was going to be really important. So one of the things we did was we funded Black Dog to do a research project which ended in the lifespan funded trial. Now, you might remember Helen Christensen came up with the lifespan model, which looked at an integrated approach to suicide prevention, combining strategies that have strong evidence base around the world. When that was published, and it got a run in the Sydney Morning Herald again, Helen got a phone call from the Ramsay Foundation, because Helen had said, we'd also funded her to say, what do you think it would cost to implement a trial? And they came up with a figure, I think of somewhere between $15 and $16 million. Helen got a phone call from the Ramsay Foundation on the day the article went out saying, we'll pay it. Bang, And so suddenly you had a funded trial where they could engage with New South Wales Health and work out, and of course it's all gone on from there, and I want to come back to something. We also funded research with the Kirby Institute around psychosis, and they have since produced remarkable evidence-based reports around demonstrating that where treatment follows, of course, what you get with, I'm talking about the criminal justice system, what you get, of course, is far less recidivism amongst that cohort of people than you do with the normal prison population. And that's it's something that's very hard for people to accept, and you might have seen something that ran on TV last night on Channel 7, but there's a lot of fear and stigma and discrimination about people with severe and persistent illness. And what Kirby showed through their research was that if you can follow up, you can provide the care that's required, if you can do it early, you can avoid lifetime issues. You won't avoid the illness, but you will avoid the disability. If you can follow up after illness, then you can reduce, particularly with the justice system, issues of recidivism dramatically. You just have to fund it. So oftentimes when we talk about things like, has someone got a treatment-resistant illness, What we really mean is we haven't bothered to fund what was necessary. And I'm so pleased today, and we push this in the plan, that no one should get a badge of having a treatment-resistant schizophrenia or any other treatment-resistant illness unless there's been some sort of, true tertiary review by true experts who look at them in a longitudinal way, even doing things like they do at the Forensic Hospital now, where they tap into the Californian Institute. Because we see a minuscule number of people. In fact, in Australia, it's very hard to get a statistically relevant sample on anything from schizophrenia to ECT to whatever. And so looking overseas to partners who have got much bigger databases helps. And so they regularly look to the Institute in California to look at whether or not they can assist them with a treatment model for a person with, say, schizophrenia. And oftentimes what that reveals is it wasn't they were treatment resistant, we just hadn't got the treatment right. And it's a stigmatising way of looking at someone with an illness to blame them for having the problem rather than looking at our response. And so I was very pleased. Can I just say, can I just mention a couple of concerns? I don't know how I'm going for time, but they say I've got 5 minutes there. I just want to say, look, firstly, an acknowledgement. I just cannot believe and very delighted to find out more about the Zero Suicide Initiative and the remarkable work being undertaken with the 20 peer-led sites. And I had a chance to catch up with Sage Green yesterday in terms of the whole safe haven development. And it just sounds like a brilliant initiative. And so I congratulate New South Wales Health and for everyone who's involved in that. It made me, yes, and they do deserve a round of applause. Because it made me think, when we were looking at this, we were desperately keen to try and explore concepts of warm rooms in communities where, and this was particularly in regional communities where oftentimes a person who appeared to be having a sort of a relapse of illness, a crisis, would be picked up by a police car or an ambulance and taken away to another town where the hospital was. And oftentimes police and ambulance would say, look, this is so frustrating. It's frustrating for them, but it's really frustrating because we get them to the hospital and by the time we get them to ED, there's sort of things have de-escalated, they've calmed down, and then we've got to drive them all the way back again, But the really big issue was that poor person had this whole crisis response, which maybe if there'd been a warm, safe space in their town, could have meant none of that was necessary. And of course, the safe haven concept is exactly that. And again, I don't know exactly what its reach is because I know it's motivated by obviously needing an appropriate response to suicide. But in a broader sense, why should anybody unnecessarily be admitted to hospital if we can find a way of ensuring they get an appropriately peer-led response? And obviously, of course, things have to be done safely, but there must be enormous scope for this. And I think the safe haven model could well help guide us. Look, the other thing, and again, I've got a sibling with mental illness and I've had too much experience over 30 years with her seeing the same inadequate response during a crisis that it frustrates the hell out of me, and it annoys me that as Mental Health Commissioner I wasn't able to change. But the thing that I wanted to push then, and I would push now, is we need to have an approach like in the UK where they have the crisis care concordant model, where basically police, ambulance and community-based, hospital and community-based teams all agree to give a guarantee of service to somebody with a recurring severe and persistent illness, that if you call, we will respond to you in a particular way. We will respond first as if we know you. We will respond in a way that has regard to your history of trauma. We'll respond in a way that doesn't see you shackled. And I can tell you in my own family to know that my sibling has been handcuffed naked and carried out into an ambulance. Now this is just, I'm not saying, I feel the fact is the arrangements weren't in place. I'm not a criticism of those who are directly involved in that. What I'm critical of is the fact she's been the same person for 30 years engaged with that same service. And they should know her. So if someone calls for her, they should say, oh gosh, yeah, we know her well. We know these are her issues, we know these are her needs, we know these are her triggers, but that's not what we have today. I mean, we may be doing it better in some places, and I know the PACER model of mental health nurses going out is good, but it's certainly not everywhere. And yet, we should be able to get that right. And maybe not for someone having a first episode, but for someone who's 30 years into episodes? Surely we should be getting that right by now. Can I also say, as he says, desperately trying to meet the timeline, can I just say, I suppose, of you, and look, you know, you are the experts in your own field, and I know there are many challenges to successfully being a peer worker. Most obviously, I suppose, and it's a concern always, that you should be provided the support and backbone framework to ensure that you're not captured or overborne by the treating team. Now, that's not a criticism of the treating team, but ultimately you should never have to forget why you're there. You know, you're not, and it may be that while you're there will undoubtedly advance the model of care and will undoubtedly advance what the treating team's trying to achieve. But the fact is, you're not subservient in that. Your voice should be heard. So you shouldn't be co-opted. They should respect your stance and your separateness in these things. So I think peer workers, like mental health commissioners and commissions, really can't afford just to become part of the background wallpaper. We shouldn't just be part of the furniture. They must maintain the status as change agents, and with that comes an acceptance that at times they're going to be disruptive. Not rude, not noisy, but certainly challenging when needed. Peer workers also need to preserve their own mental health and wellbeing. And whilst I think I've made it obvious, I think the NDIS has been a game changer and we need to support it and embrace it. We also need to recognise the toll on peer workers of supporting consumers through the lengthy and very deficits-based application process. We need to recognise that the process can be an emotional burden for peer workers. The truth is, and I used to say this back when we were getting used to it, that to successfully access the NDIS, it's almost necessary to temporarily suspend your belief in recovery. And that's not easy when recovery and the strengths approach is part of your DNA, which I know it is for you. So I don't think it's easy, and I do think you need to recognise that it will have its toll if you're assisting people through the NDIS process. And I spoke to Faye Jackson about this recently. I know Faye's very, very much aware of the need to have a narrative around this to support peer workers. The fact is, peer workers should have, and I'll come back to it, a strong supportive backbone, including a continuing need for that establishment of some national entity to argue their case and to promote their needs. And look, can I just, as a comment, we all need to keep our eye on what's happening in Victoria. Crisis is a wonderful thing. A Royal Commission into mental health and a Productivity Commission into mental health produces vast opportunities. And I just think, and again, I have to say, I only became aware of this, so I'm really behind the times. I just thought it was a remarkable thing to see Mary O'Hagan appointed as the Executive Director for Lived Experience. I mean, that's a big commitment, you know. Mary's no slouch and won't tolerate pretense, and so she'll call it out, I know. Can I also say a great thing about Victoria in this time of trying to do something differently is the fact that they're embracing open dialogue. And one of the things I ran at the Commission was an open dialogue consultative group to try and support open dialogue as it established in New South Wales. And I'm still having talks with them now. I mean, it's an opportunity to embrace something in a completely different way, to make sure that families involved in a really positive way when it can be right from the outset. So the fact that Victorian Health has said, I don't know how this is going to work, but we're going to do it, is a really big leap of faith. And it's good to look to others who through crisis are doing something, because it often provides a guidance for us. So look, can I just say in closing that none of us in the mental health space, and I do mean none of us, can afford to be tourists on the journey to reforming our approach to mental health and wellbeing. Whether in terms of crisis response or preventative action, we must call out what is unacceptable, we must remain curious and ambitious for what can be done better, and we must never, ever, ever forget why we are here. Thank you.